evaluation of back and leg pain. I have no relevant disclosures for this. The pathway of this talk will be looking at the epidemiology and all of anatomy of the spine, going through a differential diagnosis, the initial workup, imaging, and then very briefly on treatment, because a lot of the discussions later on in the day will go into detail on treatment options. So you'll notice a lot of similarities between this lecture and the previous one in terms of the epidemiology and natural histories, because there's a lot of overlap. Low back pain is extremely common. It has a lifetime prevalence of 60 to 80% of all people. 23% of the global population is affected by episodes of back pain persisting greater than 1 month, and it's a leading cause in the United States of disability among adults. It's also extremely expensive. It costs about $100 billion just low back pain in the United States annually. Despite it being very common, 80 to 90% of cases resolve within 6 weeks without significant intervention. It does have a high recurrence rate. 20 to 30% of people will have recurrence. And the associated risk factors are sedentary lifestyle, occupational driving, chronic cough, pregnancy, lifting, tobacco. Well, these are the risk factors for recurrence. One of the reasons back pain is difficult to manage, difficult to treat, and resistant to treatment is because there's a lot of things that can contribute to it. So really any structure that's innervated in the low back can contribute to back pain. These are the vertebral bodies, facet joints, nerves, the intervertebral discs, paraspinal muscles, sacroiliac joints, then things that are not within the spines, like trochanteric bursitis and hip osteoarthritis, as Dr. Jegede mentioned in his talk. So when we see a patient, I think we're tasked initially with deciding whether this is one of the million patients that have low back pain that's run-of-the-mill or bread and butter that's going to resolve with very little intervention, or whether this is something that we should be concerned about and warrants further intervention. And so I like to think of the differential between urgent and non-urgent. And so the non-urgent differential is broad. It includes degenerative arthritic processes, annular tears, disc degeneration, neurologic compression, degenerative disc disease, paraspinal muscle spasm, instability, compression fractures, spinal deformity, inflammatory arthritis, fibromyalgia, extraspinal things like abdominal or visceral causes, and previous surgery. Or the urgent differential is really falls within one of 4 buckets: infection, malignancy, unstable fractures, or neurologic compression with deficits. So this is an example of an urgent an urgent diagnosis. This is a patient with saddle anesthesia, acute lower extremity pain and weakness, and an MRI showing severe stenosis, or on the right side of the screen would be a traumatic patient with instability. And just to touch on Cauda-Equina syndrome specifically briefly, this is probably one of the most common and thought of urgent lumbar diagnoses when we're evaluating and treating lumbar spine patients. There's a difference between Cauda-Equina compression and Cauda-Equina syndrome, and I think that if there's one important thing to take from the slide, is that Cauda-Equina syndrome is a clinical diagnosis and not a radiographic one. There will be plenty of patients that have severe compression of the Cauda-Equina roots. We'll see that on radiology interpretations. We'll get those patients referred for evaluation treatment, but in the absence of this constellation of clinical symptoms, it's not inherently concerning. So the symptoms to look out for: pain is usually acute, progressive, severe, debilitating pain, radiating to the back of the thighs and legs, numbness in the saddle distribution, so perianal groin numbness, tingling. You can have acute, progressive weakness in the legs. You can have atrophy in the calves, so that's more chronic. And then you can have bowel or bladder incontinence, which is generally one of the more advanced findings. Any patient with any semblance of these clinical characteristics warrants immediate workup with immediate advanced imaging. And if you have these symptoms with an MRI, like you see on the bottom right here showing severe central compression, that essentially confirms a diagnosis of Cauda-Equina syndrome, and that warrants surgical decompression. Acutely, there's a bit of conflicting evidence on the timing of this, but typically within 24 to 48 hours. So I like to think of the initial evaluation in an algorithmic way, and the point of the algorithm really is to distinguish scary things versus run-of-the-mill bread and butter back pain. So in my thought process is, I see someone with low back pain, I first want to know if there's a neurologic component. If there is a neurologic component, is there advanced or progressive neurologic deficits? If that's yes, it gets an expedited workup with advanced imaging. If there's not progressive or advanced deficits, so if the patient just has radiating numbness, pain, tingling, maybe very slight weakness, has the patient tried conservative treatment? If they haven't, they get defaulted into the conservative treatment algorithm. If they haven't failed, then they get advanced imaging. If there's not a neurologic component, are there red flag symptoms? If the answer to that question is yes, they get an immediate workup. If it's no, then they get defaulted into the conservative treatment algorithm. And so this slide and the next slide just list a bunch of red flag symptoms, I think some of which you might look at and maybe disagree with, but the general gist of it is we're trying to be suspicious, or trying to rule out cancer, infections, fractures, and progressive neurologic decline. So history of cancers, unexplained weight loss, age greater than 50, which I think would hit pretty much red flag the majority of the patients we see. So you might rightfully disagree with that one. Failure despite conservative treatment, night pain, history of smoking, known osteoporosis or osteopenia, dish, trauma, any infectious clinical concern which could suggest an infection or an epidural abscess, and then progressive weakness or neurologic decline, which could suggest an urgent neurologic issue. So The initial evaluation of a back pain patient or back and leg pain patient revolves around these three things: the history, exam, and the imaging. The history is used to sort mostly through that algorithm. So is the pain radiating or not radiating? What's the duration of symptoms? What have they done currently for the management of these symptoms? Do they have a history of spinal issues? And do they have any relevant age or medical comorbidities? I think these questions alone can help lead us to the right answer on the vast majority of patients. The exam is really important. We'll go into some detail about that. Imaging, I always get 4 views, AP lateral flexion extension x-rays on every patient who comes in with lumbar spine issues. Admittedly, there's not great evidence to support the use of routine imaging in uncomplicated spine pain patients. However, I think in the community that we work in, the patients that we serve, I think they would be unsatisfied oftentimes without that. Also, for those of us that are treating patients as a spine specialist, often get referrals from other providers, therapists, so on and so forth. And it's nice to have the imaging available in the room to help give the patient some prognostic information. The physical exam revolves around the inspection, palpation, range of motion, and a neurologic exam. Inspection is important. You want to see the patient when they're walking into the room. Do they have a slap foot gait? Do they have a lurch or a Trendelenburg gait? Do they have an obvious deformity, which might clue you into scoliosis or possibly a fracture? Palpation is informative. Are they in muscle spasm? Do they have SI joint pain? Is there muscle atrophy? Range of motion is important to look at too. A little bit less, in my opinion, looking specifically at lumbar spine range of motion, because if these patients are in pain, that's going to be limited regardless. But as Dr. Jegede said, it's important to look at the hips. There's a huge overlap between those symptoms, and I think a good hip exam, which often gets overlooked, can be really a diagnostic. And then the neurologic evaluation is extremely important. I think it's worthwhile to take a minute just to review a basic concept of the lumbar spine anatomy in terms of the nerve roots in order to kind of really understand the neurologic exam. But when we look at any level of the spine, so we'll take L4-5, for example, there's really two different nerve entities that we're looking at. One's the exiting nerve root, which is the nerve leaving the foramen at that level. So at L4-5, that would be the L4 nerve root. And then there's the traversing nerve roots, which can be L5 and all the remaining sacral nerve roots. However, typically it's the next most caudal. So L5 is typically referred to as the traversing nerve root. And in the axial cross-section below, on the bottom right of the screen, you can see that the spine is broken up into these 4 anatomic regions. A is the central canal, and that's where you'll hit mostly the traversing nerve roots. So central stenosis can affect the nerve roots there. B is the lateral recess, which is where we see most of the compression in the traversing nerve roots, because that's a narrow anatomical space, and it's also right below the facet joint there, which becomes hypertrophic with degeneration, and that space gets smaller. And then location C is the foramen, which will affect the exiting nerve root at that level, and D is the extraforaminal space, which again will affect the exiting nerve root. So with this in mind, we go through a neurologic exam, which includes dermatomal analysis, myotome analysis, reflexes, and rarely, but when appropriate, pelvic and rectal examinations, usually in the evaluation of cauda equina. So my version of a lumbar spine exam is, as this chart explains, trying to parse dermatomes and myotomes with a nerve root specific exam. So I bundle L2 and 3. Usually patients are complaining of anterior thigh pain, not radiating distal to the knee. That's how you can sometimes differentiate an L3 versus an L4 radiculopathy. The myotome would be the hip flexors or quad. L4 dermatome, anterior lateral thigh, distal to the knee. And oftentimes you'll see tibialis anterior affected by compression of that nerve. L5 is lateral leg, lateral thigh, dorsum of the foot, and this has a little bit more broad array of deficits in the myotome. You can have tibialis anterior being affected, the EHL and hip abductor. So this is where you can see a Trendelenburg gait. And then S1 is the posterior leg, posterior thigh, plantar aspect of the foot, and oftentimes I'll examine the gastroc soleus for this. And so it's all well and good to have that kind of framework in mind, but the question is it accurate? And the simple answer is no. This is a pretty interesting study done by surgeons who wanted to create a heuristic map of myotomes based on lumbar nerve root stimulation. Excuse me. So after surgeons would do decompression, they would use electrical stimulation on the nerve root specifically and detect muscle activations distally with EMG. And what you'll see is that a significant number of nerve roots innervate a broader range of muscles than expected. So we might consider gastroc soleus as S1, but you can see from this chart that there's a significant contribution from L5. Tibialis anterior has a wide contribution from L4, 5, and S1. And so it might not just be simple textbook myotomal patterns. The dermatome is has the same issues. Most of the available anatomic literature we have on the establishment of dermatomes is based on intermediate or poor data. In the good data, the maps differ significantly. This is a sort of a composite dermatomal map based off of the good, quote unquote, good data. And all the areas in white on the anatomical body are areas that have so much overlap between the studies that you can't predict what nerve root will be affecting that area. So their conclusion was that the current dermatomal maps are inaccurate, and the evidence shows that large blank areas where overlap and variability are the rule. So there are tests when someone is in our office with low back and leg pain to determine whether the leg pain is from a nerve impingement or not. The straight leg raise test is is one of them. Elevation of the leg with an extended knee greater than 35 degrees will elicit a stretch phenomenon of the nerve over the compression of the disc, which can reproduce symptoms. This is a specific finding for radiculopathy. The slump test is a sort of modified straight leg raise where you also flex the cervical and thoracic spine. This puts the entire neuraxis on stretch and will reproduce similar symptoms. This is more of a sensitive test. The femoral nerve stretch test is looking for upper lumbar nerve herniations, a bit less commonly done because, as you can imagine, proning a patient and extending their hip in this way is going to be extremely uncomfortable in an acute pain patient. And then an important part of the exam is looking at the SI joints. The area SI pain in that region can be affected by facet arthritis, lumbar radiculopathy, or intrinsic joint issues. And so distraction, thigh thrust, compression, Faber maneuvers, and the Gainsland test can help identify intrinsic SI joint pathology, which has a totally different treatment algorithm. And then when patients come in with leg pain, it's not always unilateral, classic radiculopathic dermatomal pain. Sometimes in patients with severe stenosis, it's vague pain, heaviness in the legs, gait intolerance, sort of a composite diagnosis of neurogenic claudication. And when we have these patients, it's important to distinguish between neurogenic and vascular claudication. This is a sort of a nice listing of ways to help us distinguish this. But fundamentally, some of the differences are that neurogenic claudicating patients will have relief with cessation of activity and bending forward, as bending forward increases the space available for the nerve roots in the lumbar spine. They also will have a normal pulse exam. Vascular claudicatory patients will have symptoms with any metabolic increase in activity. They might have hair loss in the legs, and they'll obviously have an abnormal pulse exam. And so although I think, from maybe a primary care point or an urgent care visit point of view, it's not necessary to get images on all patients. I do. And I wanted to see as many S words as I could get up on the slide, I guess, with these x-rays. But I think having these images available is informative. The conversation of back pain and prognosis I might have with the scoliosis patient on the left will be radically different than the conversation I'd have with the spondylolysis patient on the right. There's value in flexion extension films. As you can see, the spondylosis and instability x-rays are of the same patient. And you can see when she goes into flexion, she has L4-5 dynamic instability. And these are all important pieces of information to give the patient a good understanding of their prognosis and any surgical discussions that you might have. The other really important factor here is that x-rays can help us pick up compression fractures. These are really common and portend a pretty poor prognosis. So 27% of postmenopausal women will have compression fractures. 2/3 of these are clinically silent. And not that they don't affect patients, it causes decreased quality of life, but they won't report an acute fracture event with severe pain. If you look at all the Medicare data and you look at mortality rates and survival rates after vertebral compression fractures, you'll see at 3, 5, and 7 years, the survival rates are 53, 30, and 10%. Obviously, there's a ton of confounding data that would contribute to that, but it's just important to know. And it's important to know because if you have osteoarthritis or osteopenia, in the lumbar spine, there's a high likelihood that you're going to have it elsewhere. And whereas a vertebral compression fracture is common, a fragility fracture in the hip has a high mortality burden. And these are preventable. So this is somewhere where we can intervene, recommend treatment for osteoporosis, and actually save someone's life. The question is, after the initial evaluation, when is advanced imaging worthwhile? When do we get it? Judicious MRI use is important because abnormal findings are extremely common. Up to 40% of patients 20 to 40 years old will have degenerative changes on their MRI. And at 70 years old, this goes up to 80%. If you get MRIs on asymptomatic patients, only 36% of them will be normal. So if you get an MRI on somebody, more likely than not, you're going to find something. And so when do I get it? I refer back to the algorithm here. You get an MRI if you have advanced progressive neurologic deficits, if you fail conservative treatment, or if you have red flag symptoms. Other advanced imaging options that are helpful in the treatment of lumbar issues: MRIs with contrast are helpful for the evaluation of tumors or recurrent disc herniations. CTs are beneficial for surgical planning, understanding bony anatomy, or postoperative evaluation. You can see these 2 MRI cuts are in patients that have lumbar pedicle screws in, and you can see that the image quality is degraded substantially to the point where there's not really much information you can glean from these tests. So CTs and CT myelograms are helpful in these circumstances. And then a PET scan is much less common, but it can be done to evaluate for occult non-unions in post-surgical patients, or you can use it to assess for pain generators. I am not going to cover these conservative treatment options because we'll go in detail, but fundamentally physical therapy, medication management, interventional therapies. The role for surgery, there's very little role for surgery in just the management of back pain, but if you wanted to sort of have a broad understanding of it, the role for surgery only comes in when back and leg pain patients have associated red flag symptoms and a diagnosis of an operative pathology. So that's the urgent bucket, or back and leg pain patients that are refractory to conservative treatment in otherwise appropriate surgical candidates. And there's a lot of good talks this afternoon that will go into this in detail. So in summary, back and leg pain are common. Although most self-resolve, they have high recurrence rates. Acute low back pain without red flag symptoms can be treated conservatively, oftentimes without any imaging. The presence of red flag symptoms should warrant urgent workup and referral, and symptoms that persist beyond 6 weeks warrant further treatment and advanced imaging. Thank you.